Alright, welcome to Road to 250. Today we'll talk about cardiac pathology, specifically pericardial diseases, aortic dissection, and cardiac tumors. So pericardium anatomy, it consists of three layers: the fibrous pericardium, the serous pericardium, and then within the serous pericardium there's two different types. There's the parietal layer and the visceral layer, and the pericardial cavity is between the serous layers. And the pericardium is innervated by the phrenic nerve, so when you have pericarditis, you often get referred pain to the shoulder. So the diseases that we'll talk about today are pericarditis, tamponade, and constrictive pericarditis. And this is from first aid. Just wanted to highlight the main points from what they said. Pericardium has the three layers as we've talked about, and the pericardial cavity lies between the parietal and the visceral layers of the serous pericardium. And phrenic nerve, and this can often refer to pain to the shoulders, so just keep that in mind. And so specifically for pericarditis, it's the most common pericardial disorder, and it's basically an inflammation to the pericardium, and it's immune mediated. The details are not well known, and it may reoccur after treatment. So the clinical symptoms that you will see with this is chest pain. Usually it's sharp chest pain that's worse with deep breaths, and it's worse with lying flat. So most of these patients will sit up or lean forward to counteract that pain because it feels better. You may see fever, leukocytosis, and an elevated ESR with these patients. So this is an EKG that you would possibly see for a patient who has pericarditis. In this, it's going to be very hard for me to tell you exactly because in every lead almost the ST segment is elevated. So in leads 2, here you can see there's an ST segment elevation in V2. There's an ST segment elevation in almost every single lead. So that's something that you want to keep in mind, that if you have an ischemia versus a pericarditis, in ischemia you would have an ST elevation as well, but it's often localized to one location of the heart, such as the anterior wall, the inferior wall. But in pericarditis, there's an ST segment elevation in almost every lead. So that's how you can differentiate between the two. So more specifically, I wanted to talk about this EKG specific. This is specifically looking at lead 2. And here your PR segment is between, so we're going to take this here. So it's, if you look at it, it's kind of going on a downward angle. This picture will tell you. So with pericarditis, you often see a PR depression. And with pericarditis, technically there are 4 stages of EKG changes. Stage 1 is a diffuse ST elevation and a PR depression. Stage 2, which will roughly occur 1 week after the stage 1, these patients will again turn back to being normal, so their EKG will be normal. In stage 3, they can also see a T-wave inversion. This is also 1 week after stage 2, and then stage 4, they'll go back to normal. So there are various changes in EKG findings, but the key things that you want to keep in mind are ST elevation in almost every lead and then PR depression. So those are the 2 things that you want to keep in mind. So etiology for pericarditis, it's usually idiopathic. There are some viral causes. Classic cause is Coxsackie virus, and it often follows a viral upper respiratory infection. There are bacterial causes, basically, or spread of pneumonia, something that leads to complications of surgery, and tuberculosis is a big one. And then there are some fungal causes as well. And the complications of the surgery one is basically if the bacteria is introduced to the pericardium, it's how you can get pericarditis. Other causes are uremic or renal failure, and often you see pericarditis in post-MI. So fibrinous days after MI, or Dressler syndrome, which occurs weeks after an MI. So typically that's when we'll see it most in most of our questions. And there are autoimmune diseases that can also lead to pericarditis, such as rheumatoid arthritis and lupus. So just to keep those in mind. So the physical exam for pericarditis, you'll see a pericardial friction rub. You can hear a scratchy sound during systole and diastole. And the treatment for this is NSAIDs, steroids, and colchicine is apparently another good one to give these patients. Colchicine, the way this mechanism, it's complex, but it inhibits the white blood cells. And colchicine, as we know, is useful in gout, but also familial Mediterranean fever. And it's added to NSAIDs to lower the risk of reoccurrence. So, from first aid, it's basically an inflammation of the pericardium, as you can see here. Commonly presents with sharp pain and then aggravated by inspiration and relieved by sitting up and leaning forward. And presence with friction rub ECG changes include widespread ST elevation and PR depression. So we've covered most of this, but radiation therapy can also cause acute pericarditis and neoplasias and autoimmune such as SLE and rheumatoid. Any questions about this one?
Nope.
So we're going to talk about tamponade. So this is an accumulation of the pericardial fluid in the pericardial sac, which then leads to a high pericardial pressure. And basically, due to this high pressure, it will restrict filling of the cardiac chambers. And the amount of fluid is variable. So here's what I mean by this one. When you have an acute accumulation, when you have a bleeding or a small amount of fluid, the pericardium has no time to stretch out that acute change. So then that's why you see with a small amount of fluid can lead to a big damage with the increase in pressures and decrease in filling. However, in chronic accumulation, the pericardium has time to stretch. Thus, large amounts are required before the pressure is high to restrict the filling. So if you have acute causes, it just doesn't have enough time to expand out like you would see in a chronic cause. And that's why in most cases, acute causes cause the restriction and filling much quicker than, such as a cancer patient. So there's something to keep in mind. And the causes, obviously, is cancer metaplasia to the pericardium, uremia, pericarditis, or trauma. And the treatment for these patients will be drainage or refusion. So the clinical features, you'll hear distant heart sounds. You often get dyspnea because of the high left atrial pressure and pulmonary edema. And you also see an elevated JVP. That's due to the right atrium cannot fill normally, so the pressure gets elevated and it backs up. You'll also see pulsus paradoxus, and we'll cover this one a little bit more detail coming up in the next slide. And Beck's triad. Can anybody name the Beck's triad for tamponade?
JVP.
Okay, yeah, elevated JVP. One more. So you get distant heart sounds, elevated JVP, and hypotension. I've kind of learned that this only occurs in trauma, but it's not necessarily true. You can hear Beck's triad in all cases, but you'll probably hear it more in cases of trauma. And that's due to basically what I talked about doesn't have enough time to stretch out. So you would probably hear this more often in patients who have not had that time to stretch. The pericardium and the pressure will increase. So the severe impairment will lead to a severe impairment of the left ventricular function and thus your low cardiac output, and that's why you get the hypotension. And then in slower effusions, as I've said, the pericardium stretches and dilates, which allows more time. So it doesn't actually cause most of these signs and symptoms, but it can. So don't assume that it's not. But just the way I've learned it. So I have a couple pictures here. You have your left ventricle and your right ventricle, and then the septum in between. And then these white lines out here, and there's actually should be one more right here. This is where all your fluid is. So this is your pericardial fluid. And once the pericardial fluid pressure increases, it will cause these chambers not to fill normally. And another thing that you'll often see is this called a water bottle sign. It's basically a non-specific finding, but the heart becomes so enlarged it looks like a water bottle. So this is what you would see. And these are non-specific signs, but you would see this in a tamponade patient. So pulsus paradoxus. It's a classical finding in tamponade. Systolic BP falls slightly on inspiration, and it has an exaggerated flow greater than 10 millimeters per mercury, and that's why it's pulsus paradoxus. So if a severe pulse, the pulse will eventually disappear. I wanted to go through this real fast. This is how I kind of put it all in my mind. So when you do have an inspiration, you get a great venous return. So what would normally happen is your right ventricle will increase in size. However, I think it's good to draw this. When you're going to have, so this is your right ventricle. And then you have your pericardial fluid around. So the right ventricle cannot distance itself outward, so it can't go out this way because of the fluid. So if you have a great amount of fluid surrounding the ventricles, it can't push itself out. But so what it does, it expands against the wall between the right ventricle and the left ventricle, and thus the septum will bulge. This is why you see the septum bulge, and that shrinks the size of the left ventricle, and that will decrease your cardiac output. So if you can't remember as to why the cardiac output would fall in a patient who's inspiring, this is a way you can think about it, especially if they have tamponade, is because when you inspire, you have more venous return, causes the right ventricle to increase in size, but due to the pressure, it's only going to increase against the septum, and then it's going to cause your cardiac output to fall. So this is why when you, and I guess I have a side note here, when you have an increase in venous return, your tricuspid regurg and right-sided heart murmurs get louder with inspiration, is because you have the increase in venous return and increase in right ventricular size. So that's how you can also put the right-sided heart murmurs get louder. Anybody have any questions with this one? All right. You can also see pulsus paradoxus in patients who have asthma and COPD. So this is when you inspire, there's a low left-sided flow, and it causes the pulmonary pressures to fluctuate, and that's why when you see a large drop in the left-sided flow, it can cause pulsus paradoxus. But I really just wanted to cover the main part as to why it happens here. All right, so there's some pictures that I wanted to talk about. In tamponade, this is an EKG finding. You'll just see the things that I want you to see here is the level of these segments. They're not equal, so some are high, some are low. And it has sinus tachycardia, and there's low voltage. So EKG sees less electricity due to the effusion. So you can see these alternate sizes. So one is bigger and one is smaller, and that's due to the less electricity because of the effusion. And in tamponade, you will also see X descent and a Y descent. So, or a blunted, prominent X descent and a blunted Y descent. So this is your venous filling chart, as we've kind of covered before. And normally your X is right here and your Y is right here. So what happens in the X phase is there's a fall in the pressure after the A wave, as you see here, and that's after relaxation of the right ventricle. right atrium. So the right atrium is relaxing, and that's why you see this fall down. And in the Y, normally there's a fall in pressure after the V wave because the filling of the right ventricle from the right atrium. So that's normally what is happening. However, in patients who have tamponade, you will get a greater R, a prominent X descent because, so I'm going to draw it, sorry, should have drawn this earlier. So you have your right ventricle with your valves, and then you have your right atrium. So this is your atrium. Okay. Alright, and then obviously you have this sac around. So when the right ventricle contracts, the surrounding volume here should basically, so you have this fluid. So when this contracts inwards, all the fluid up here will start to drop down. Right? So allowing the right ventricle to relax a lot more. So this right ventricle will have more space to basically bulge out and relax. And that's why you get a greater X descent. Because you're giving the right atrium more space, it's going to blow out more. Does that make sense? Yes, no?
Can you explain that again?
Yeah, so here, I'll do a different color, so hopefully that makes more sense. So when your right ventricle is constricting, right, when it constricts, it's going to come inwards, correct?
Mm-hmm.
So that allows all this pressure out here, the pericardial fluid that's out here, to come down because this is moving inwards. So more fluid will be able to come down here. That means less surrounding the right atrium on the top. And that will allow the right atrium to basically relax even more. So this right atrium will have the ability to expand out, and that's why you get a much deeper X descent.
Okay.
So when it expands out more, basically I'm assuming it fills more, and that's why you get this lower. So the right atrial pressure decreases and during RV contraction in systole because it doesn't have the fluid on the outside that it normally did because it has slid all the way down.
There's less wall tension.
Correct, yeah. And so it's able to expand out. And then in the blunted Y descent, there's just poor right ventricular filling and diastole, obviously, because it's kind of constricted. So does that make sense?
Mm-hmm.
All right. And one last thing, this is basically an equalization in pressure. So here, I wanted to talk about the pressure in the right, all the pressures will kind of hit this max here, 20, 20, 20. So your pulmonary capillary wedge pressure is basically looking at your left atrial pressure. So that's also going to be about the same. So now what I mean by here, so if you have the same thing, here you have your right atrium, I'm only going to draw that one, and the surrounding fluid. So what you're trying to say here is, let's say the surrounding fluid has a pressure of 20. The right atrium will only go up, or basically will go up to this 20. It won't go beyond that. It won't go less than that. That's what I mean. The pressure will equalize. The pressure on the outside is similar to the pressure on the inside. But all the pressures will rise until it matches that pressure to equalize. After that, it can't basically fill up anymore. It can't constrict anymore. So this is seen in tamponade and pericardial constriction, that these pressures, when they can't relax, they'll get really high. So they're higher than normal, but then they'll only go up to a certain point and then just stop because the pressures will equalize, essentially. So just know that you will see high pressures, but at some point they will just equalize. So in cardiac tamponade, it's a compression of the heart by the fluid, such as blood or effusion in the pericardial space. So where you see here is basically the pericardial space. and that will lead to a decrease in the cardiac output. And this is what it says here: equilibration of the diastolic pressures on all four chambers. So that's where all the chambers will equilibrate in this pressure. And the findings will include Beck's triad, increase in the heart rate, pulsus paradoxus, and then the ECG can show low voltage QRS and electrical alternans. And it's what I said was due to the effusion, but it's due to the swinging movements of the heart and a large effusion. And pulsus paradoxus is decrease in the amplitude of the systolic BP greater than 10. And it can be seen in other things such as asthma, obstructive sleep apnea. So just keep that in mind. Something that's not in first aid is constrictive pericarditis. This is fibrinous calcified scar in the pericardium, and it's basically a loss of elasticity. So it becomes stiff, thickened, and sticky. And this can result in many disease processes such as pericarditis, radiation to the chest, and heart surgery. In constrictive pericarditis, obviously you'll see dyspnea and prominent right heart failure. So the right ventricle is the most impacted in these, and there's marked elevated JVP, low extremity edema, liver congestion, and may lead to cirrhosis. So there are signs and symptoms that are similar to right heart failure, but these patients with cirrhosis here, just if you want to differentiate between cirrhosis and constrictive pericarditis, in cirrhosis, the JVP won't be elevated, but in constrictive pericarditis, the JVP will be elevated. So keep that in mind. And then in constrictive pericarditis, you'll also see Kussmaul sign, which is inspiration increasing the venous return, and there's a slight fall in the mean JVP. So this is when you would see inspiration and increased venous return, this is what you should see in a normal patient. But with a patient who has a Kussmaul sign, they'll have an increased JVP with inspiration. And that's because the ventricles cannot accept the venous return. And that's due to the ventricles being surrounded by a calcified sac, and it cannot expand. So it will lead to a constrictive pericarditis. You can see an increased JVP and restrictive cardiomyopathy and right ventricular myocardial infarction, but it's not seen in tamponade. So that's a differentiation here. It's not seen in tamponade, but it's seen in constrictive pericarditis. So the only thing written in first aid, I'm sorry, I realize these pictures are more blurry than I thought, but in Kussmaul sign, you have an increase in JVP on inspiration instead of a normal decrease, what you should see. So the bud is basically backing up, and it's causing the JVD. And this is seen in constrictive pericarditis, restrictive cardiomyopathies, right atrial or ventricular tumors. But first aid doesn't really cover this in greater detail, so I just threw this in here. And for this one, in pericardial constriction, the right ventricle is adherent to the pericardium, so when it stretches out, it sticks to the pericardium. So in diastole, they snap outwards. So if I had to draw a picture, this is your right ventricle, and you have your atrium. Just draw the sac in different colors. So here's your pericardial sac. So when I'm trying to draw it as I'm saying it, but when the right ventricle is kind of adherent to this pericardium, so when these things, so when in diastole, when they snap out this way, they're going to go rapidly outwards. So this wide descent is really rapid to begin with, right? So that's when it's snapping out. But then the right ventricle can't fill anymore because of this calcification that's surrounding this pericardial sac. So apparently that's calcification. And that causes the pressure once it reaches that level to suddenly go back up. So that's why you're seeing this rapid wide descent and then an increase again. So there's a rapid filling of the right ventricle because it's snapping out, and then there's an abrupt stop to the filling, and then the pressure will start to rise again. So that's basically it, and there's more blood that's being drawn out from the right atrium into the right ventricle, but because it reaches this calcification, the pressure will then come back up. Hopefully that makes sense. So, like it says here, myocardium is adherent to the pericardium, and in diastole, there's a rapid relaxation and suction of right atrial volume, but then, as we said here, there's an abrupt stop in the filling because you can't push out anymore, and that will increase in pressure. So, things that you can remember this with is pulsus paradoxus is a classic sign of tamponade, so pulsus and tamponade. And Kussmaul's sign is a classic sign of constriction, and I've also seen in restrictive heart disease, so Kussmaul in constriction and restriction, if that helps you. I think it's a good mnemonic. So, any questions before we move on to our second topic? Okay. So, in aortic dissection, there's 3 layers to the aorta: the intima, media, and adventitia. And the dissection is basically a tear in the intima, and the blood will dissect into the intima and media, and it enters the dissection plane and spreads either proximally or distally. And that will result in a disruption of the flow to the vessels. So, So there's 2 types. There's a type A, which involves the ascending aorta and or the aortic arch. And the treatment for these patients will typically be surgery to remove it because the mortality is very high if surgery is not performed. There's a type B, which is that affects descending aorta, and that can be treated medically. And that's basically often stabilizes these patients. You control the hypertension and the symptoms. And what the hypertension does is stretches the aorta and drives blood into the dissection plane. So by controlling it, you're going to kind of stop that. And the surgical mortality in these patients are high. So that's why they choose to treat it medically rather than surgically, because the mortality rates performing the surgery are greater. So something to keep in mind. So the signs and symptoms that you would see with these patients: there's a tearing chest pain that radiates to the back. Their blood pressure will be different between their arms, so there's a blood pressure differential. And there's a widened mediastinum on chest x-ray. So as you can see here, these patients have a wide mediastinum. Additionally, you can get propagation of the aortic root. And what I mean by that, so here, what I have highlighted, and that's a terrible color because you guys can't see. Here is basically when I talk about the aortic root. So they basically dilate and stretch out when you have a dissection. And when that happens, the leaflets won't be able to come together properly, so the blood will have the ability to leak back. And that's why you see with dissection of the aortic root or propagation of the aortic root, you often see aortic regurgitation. They can get pericardial effusion and tamponade, and they can also get myocardial ischemia because there's a right coronary artery that's getting obstructed because the origins are there for it. So by disrupting the flow here, many of the vessels that come off the aorta will not get the same blood supply, so keep that in mind. And then you have propagation of the aortic arch can lead to stroke, Horner syndrome, because it's affecting the sympathetic nerve system. And then you can get vocal cord paralysis, and that is because the recurrent laryngeal nerve is affected. And basically the recurrent laryngeal nerve is a branch of the vagus nerve, and that supplies the larynx and the voice box. So when you see a compression, it's going to be in aortic dissection or in a massive left atrial enlargement because the left atrium sits kind of right around here, sorry. kind of got wider than I wanted to. And in patients, most of these patients, you're going to do diagnosis with history or an exam or a chest x-ray, but the definitive diagnosis is done via CT scan or an MRI. And in these patients, you may also see D-dimers being elevated, and that is because the blood gets into the dissection plane and many clots are formed. So it's a sensitive test, but not very specific. But some hospitals will think the normal value makes aortic dissection unlikely. So again, sensitive, but not specific. So what I'm going to talk about is kind of like the pathophysiology behind aortic dissections, and then we'll go into risk factors. So the medial layer of the aorta, why is that important? It provides the tensile strength and elasticity, and the key proteins there are collagen and elastin. So if you have a weakness in the medial layer, it can cause aneurysms or dissections. And the common aneurysm feature is medial damage or destruction. Ways of a sorum, so what is that? It's a network of small vessels, primarily in the adventitial layer, and what they do is they supply blood to the medial layer in thick vessels, such as the aorta. So when you have hypertension, it causes a thickening of this outer layer, and that what it does is decreases the vasovasorum, or the blood supply, and that will weaken the medial layer. So if you can figure out the kind of things that we're talking about here, the medial layer is greatly affected, will increase the chance of getting an aneurysm or aortic dissection. In order to get a dissection to occur, you also require tension on the wall. So it's common in the proximal aorta, so very near the aortic valve, because there's a high tension from the blood that's moving out of the heart. And it's worsened by hypertension. And it requires weakness of the medial wall, as we've discussed here. So that's also caused by hypertension and seen in collagen disorders such as Marfan and Ehlers-Danlos syndrome. So the risk factors for patients who have aortic dissections is, if you have aortic damage, hypertension is the number one risk factor. Atherosclerosis and thoracic aneurysms can also cause aortic damage. If you have abnormal collagen production, such as with Marfan or Ehlers-Danlos, can also increase the risk of having these diseases. And other causes that can cause aortic dissection is bicuspid aortic valve, Turner syndrome. It's the most common, actually, in Turner syndrome. Aortic dissection is the most common mode of death, which I didn't know. And then tertiary syphilis or aortitis used to happen a lot more in the old days, but it's kind of very rare to see that now. But it's also a possible risk factor. So from first aid, it's a longitudinal tear forming a false lumen, and it's associated with hypertension, bicuspid aortic valve, or your connective tissue disorders, such as Marfan. And it's basically a sudden onset chest pain that radiates to the back and marked unequal blood pressures in the arm. And basically you'll see the mediastinal widening and can cause organ ischemia, aortic rupture, or death. So there's two types. One is the proximal, which involves the ascending aorta, so the A for A. And that can lead to aortic regurg, as we've talked about, because the leaflets can't close. Cardiac tamponade, and the treatment for that is surgery. Or B, which is the Stanford type B, only involves the descending aorta, so below the ligamentum arteriosum, and the treatment is medically with beta blockers and then vasodilators. Any questions about aortic dissection?
No.
All right, so the last topic, and then two questions for you guys, and I'll make this very quick, are cardiac tumors. So myxomas are the most common primary cardiac tumor. Rhabdomyomas are the cardiac tumors that occur in children. However, the most common cardiac tumor overall is metastasis tumor. So anything that metastasizes here. And usually there are no clinical symptoms for the last one, and they're usually identified post-mortem. So myxomas occurs in the left atrium about 80% of the time. Usually is attached to the atrial septum, and it's benign, so it does not metastasize, and often causes symptomatic symptoms or B symptoms such as fevers, chills, and sweats, and can embolize, which can cause stroke. What else do I have? It may disrupt the mitral valve function, so you can get mitral valve regurgitation or heart failure because it's basically obstructing flow, or it affects closure of the mitral valve leaflets if it just sits on there. And it can just sit in the mitral valve, and it's called ball and valve. It's going to obstruct the flow, and that can cause mitral stenosis and then syncope or sudden death. And when you auscultate, you're going to hear a diastolic tumor plop. Most of these patients die suddenly. So in myxomas, cardiac tumors, most common heart tumor is metastasis, such as melanoma. But in myxoma specifically, the most common primary cardiac tumor in adults, and 90% occurs in the atria. I had 80%. Myxoma is usually described as a ball valve obstruction in the left atrium. So that's where you get the multiple syncopal episodes. And when you auscultate, early diastolic tumor plop sound. And then in histology, which I'm surprised they don't have a material, and that's the mucopolysaccharides, and that's what's the sticky substances that's going to stick and make it a mobile mass. And you can also see mesenchymal cells, which are undifferentiated cells, or endothelial cells, possible. In cardiac rhabdomyomas, it's tumor of the muscle cells. It's benign, and they do not metastasize. Usually in children, mostly less than 1 year of age, and sometimes it's detected prenatally. So the tumor is embedded in the ventricular wall, and most regress spontaneously. And rare symptoms from obstruction of blood flow. So usually you see multiple masses. I saw an echocardiogram of these patients, and there's actually a few masses, not just one. So with rhabdomyomas, you might see a few. And it's associated with tuberous sclerosis, and that's an autosomal dominant genetic syndrome, and that's a mutation of TSC1 or TSC2 gene. The TSC1 is hamartin, and TSC2 is tuberin, and the mutations cause widespread tumor formation. And tuberous sclerosis often occurs with multiple organ systems, and you can see numerous hematomas or neoplasias, but the most common presenting features of these patients are seizures, but they can also present with ash leaf spots, which I forgot to put on here, and angiofibromas, and then they can also have mental retardation. So a classic sign or symptom of these patients will be a child that presents with seizures and has angiofibromas or an ash leaf spot. So that's how you can, and most of those patients will have cardiac rhabdomyomas possible. So any questions with this one? All right, so I have two questions for you guys. So first one, a 55-year-old man is brought to the ED because of an acute onset of crushing substernal chest pain. He has a history of uncontrolled hypertension and type 2 diabetes. The ECG suggests acute anterior MI. The patient undergoes successful thrombolysis and subsequently is discharged. 6 weeks later, he develops fever, pleuritic chest pain, or pleuritic type chest discomfort. A repeat ECG shows widespread ST segment elevation and multiple EKG leads. In addition, a pericardial friction rub is audible in cardiac auscultation. Which of the following is most likely the cause of the patient's current presentation?
A.
Okay. Anybody else? Okay. So the answer is not A. The answer is B. This patient had an acute MI. 6 weeks later, he develops fever, pleuritic chest pain, discomfort. So yes, he does have symptoms of pericarditis. However, several what the answer is B, because that's typically known as Dressler syndrome. That occurs after MI, 6 weeks. And in Dressler syndrome, you're characterized by symptoms of pericarditis several weeks or months after trauma, MI. Clinically, you would see potential chest pain relieved by leaning forward and worsening by leaning back, which this patient didn't really say. So yes, you guys are right as far as pericarditis. However, it's not acute. It's because there's a history of an MI. And 6 weeks later, he developed a fever and portal chest pain and widespread ST elevations. So that's why it's Dressler syndrome. Does that make sense as far as the answer, Joyce?
Mm-hmm.
Yes, no?
Yeah.
Yeah.
Okay. Sorry, that was a trick question. Second one's a 64-year-old woman comes to the physician because of shortness of breath and an episode of near syncope. She is a chronic smoker and was recently diagnosed with an inoperable breast cancer. She's had a 20 kg or 44-pound loss over the past year. Her pulse is 145 and blood pressure is 85 over 40. Her blood pressure significantly drops during inspiration. The jugular veins are distended and her heart sounds are muffled. ECG shows a low voltage QRS complexes. Chest X-ray shows globular cardiac shadow. Which of the following is the most likely diagnosis?
Says A.
Okay,
Yeah. A.
that's the correct answer. Does anybody need any explanations for the other ones?
This patient's got Beck's triad, so.
Correct. Yes. Obviously the hypotension, JVD, and Motard zones. So Beck's triad is one. If you didn't know that, you can also look at the low voltage QRX complexes. And I think one other thing here, the blood pressure significantly drops during inspiration. That's the pulsus paradoxus. So there's plenty of clues in this patient to give you tamponade. Any questions?
No.
That is all I got for you.